Hello everyone, my name is Sharon Agacite. I'm a graduate student of Brandman University. Today, my presentation will be focusing on gastroesophageal reflux disease. Gastroesophageal reflux refers to the retrograde movement of gastric contents from the stomach to the esophagus. Gastroesophageal reflux disease, or GERD, is a chronic and more serious form of gastroesophageal reflux with or without mucosal damage. GERD is common in the United States. Most common symptoms are heartburn and massive regurgitation. GERD may affect the quality of life due to the extraesophageal symptoms such as dental erosion, sore throat, laryngitis, hoarseness, chronic coughing, wheezing, asthma, and bronchospasm. There are three types of GERD: non-erosive, erosive, and functional heartburn. About 50 to 85% of patients have non-erosive type of reflux disease. Esophageal damage, however, is marked by erosions, ulcers, or stricture of the esophagus. Functional GERD means that patient may have normal EGD result or normal pH testing, and yet they respond to the standard therapy for GERD. According to the National Institute of Diabetes and Digestive and Kidney Diseases, anyone can develop GERD. You are more likely to have a GERD if you are overweight or obese, if you're pregnant, or if you're taking certain medications such as pain meds, antidepressants, antihistamine, or calcium channel blockers. And finally, people are at risk for GERD if they are smoker or regularly exposed to a secondhand smoke. Multiple factors are thought to be involved in the pathophysiology of GERD. First is the transient lower esophageal sphincter relaxation that allows the gastric content to reflux into the esophagus, in which is often happens when a patient's lie flat. Next is low resting pressure of the sphincter, in which can potentially contribute to reflux esophagitis because of shorter lower esophageal sphincter. Poor esophageal acid clearance with increased volume and causticity, defects in the esophagastric motility or peristalsis, impaired mucosal resistance and other protective defenses, altered hiatal and gastroesophageal anatomy, and finally, hypersensitivity to gastric acid. The most common symptoms of GERD is regular heartburn, a painful, burning feeling in the middle of your chest, behind your breastbone, and in the middle of your abdomen. However, it's important to remember that not all adults with GERD have heartburn. Other common symptoms include bad breath, nausea, pain in the chest or upper part of the abdomen, problems swallowing or painful swallowing, respiratory issue, and some other stuff. It's important for the clinician to perform a physical exam when GERD is suspected. For example, performing an oral examination. Patients with GERD might have extensive loss of teeth enamel. Weight loss is a concern, especially in patients who have dysphagia. Respiratory wheezing or cough may be seen if there is associated asthma. Epigastric tenderness or hemocold positive stool for esophageal erosion, ulceration, or even severe inflammation. There are different approaches to GERD diagnosis. First is EGD and mucosal biopsy, which often done by the gastroenterology doctor. Barium radiography can help define the obstructions such as stricture, hiatal hernia, and esophageal shortening, to which inform any surgical approach. Esophageal pH testing, esophageal manometry, where it measures the muscle contraction in the esophagus, and finally the Medtronic capsule, where it captures and records the pH in the esophagus. The main goal for the GERD management are to reduce or eliminate symptoms, heal any esophageal lesions, and prevent complications. Lifestyle modifications such as elevating the head of the bed, lowering fat intake, quit smoking, avoiding resting flat 2 to 3 hours after a meal, obtaining a healthy weight, avoiding food that triggers the GERD, such as chocolate, alcohol, carbonated drinks, peppermint, coffee, and so on. The pharmacological treatment includes histamine 2 receptor antagonist, in which it acts on the parietal cell to decrease the amount of acid produced. These meds are available over the counter that can also use as a maintenance acid suppression or heartburn therapy in patients that don't have erosive GERD. Proton pump inhibitor are the first-line therapy for GERD because it decreases the acid secretion by almost 100%. And PPI also improve the esophageal healing to about 80%. Metoclopramide and betanicol also improve lower esophageal sphincter tone and have a prokinetic function, but they are not considered monotherapy in treatments of GERD. There's also endoscopic therapies and finally surgery. Complications of GERD include esophageal ulcers, peptic strictures, barred esophagus, hemorrhage, and perforation. Gastroenterology referral is indicated if the patient has some of the red flag signs such as dysphagia, odynophagia, new iron deficiency anemia, weight loss, fecal occult bleeding, and new onset motility disorders such as nausea and vomiting. In addition, patients may also refer to the GI doctor if their symptoms persist for 2 months despite the pharmacological treatment. By changing your diet, GERD can be prevented, or at least it relieves some of the symptoms that are associated with GERD. Some food or drinks can worsen GERD. Therefore, it's important to educate patients that if possible, avoid those foods, which include chocolate, coffee, peppermint, greasy or spicy food, tomatoes and other tomato products, and excessive alcohol drinks. And that concludes my presentation. Thank you for listening.